I'm Mahmud, President of the Society for Cardiovascular Angiography and Interventions. This is an extraordinarily stressful time for all of us as we take care of our patients, ourselves, and our families. One of the things that we've decided to do is, as SCAI, host a series of webinars that'll help us learn how best to manage the various patients that we're dealing with during the COVID-19 pandemic. Today is the first in a series of webinars, and I'd like to welcome my co-host, David Woods from the University of British Columbia. He's a professor of medicine there and the president of the Canadian Association of Interventional Cardiology. In addition to David, I'm joined by a set of panelists. We have from Emory University in Atlanta, Dr. Kendra Grubb. She's a cardiothoracic surgeon and also the head of the surgical director of the heart valve team. We have Kim Guibone, a nurse practitioner and valve coordinator from the Beth Israel Deaconess Medical Center in Boston. Bipin Shah is the director of the cath lab at the Brigham and Women's Hospital in Boston. And finally, Molly Szerlip from Baylor Plano in Texas. Now, we have a set of slides that I also want Molly to go ahead and advance, please. All right, keep going, Molly. Advance, please.
Yes, it is slow.
Okay, that's all right. So I'd like to thank both Edwards Life Sciences and Medtronic for helping and providing us a unrestricted grant to do this webinar today. Keep going. We have, this is a CME activity, and at the end of this, you'll be able to get credit for that. And we are, of course, going to have this online on the SCAI website. Our goals today are really to address the concept of what is essential versus non-essential procedures when it comes to TAVR. We're going to discuss the risk stratification for TAVR patients. We're going to provide guidance to the valve coordinators and structural heart teams as to how best to operate a TAVR clinic and hold heart valve team meetings during the COVID-19 pandemic. And we'll have some opportunity for questions from the audience as well. So let me turn to Dr. David Wood, my co-moderator and the president of the Canadian Association of Interventional Cardiology. David has done a fantastic job in leading a set of guideline documents for Canada. And David, why don't you go over your documents and your slides and share with us how you arrived at figuring out what's the best way to approach this situation.
So thanks, Shami. Obviously, we've got a wonderful, wonderful panel today, and we have many, many people on this webinar, I think well over 1,000. So I think this is an incredibly important topic. And as you know, we now have this wonderful collaboration between CAIC and SCAI. We got together about 30 different clinicians over the last 2 weeks as the pandemic was starting to escalate in Canada and tried to come up with some recommendations for interventional and structural heart teams across Canada. This was published last Monday in Canadian Journal of Cardiology. And maybe I'll just briefly take you, there's only 3 slides because I think the whole focus today should be on discussion and questions from the global community. Next slide, please, Molly. If you can just make that large. So I think a unique piece here was right from the outset, we involved a clinical ethicist, Alice Ferrani in British Columbia, to try and frame our discussion, because unlike other things, this is unprecedented, where an ethical framework can help us as we have scarce resources, significant restrictions in practice, and as we all know, significant limitations in PPE. I think if we had unlimited PPE, the level of anxiety, both for clinicians and the general public, would be dramatically different. Next slide, please. So very shortly, SCAI, in conjunction with CAIC, will host a STEMI webinar, which I know many of the same audience will attend. But while the focus has been on STEMI and access, and are we still doing primary PCI, or should we transition to a pharmacoinvasis and eventually to just thrombolysis only, depending on infrastructure. We must not forget our structural heart patients. Next slide, please, Molly. And this is key. So if you just go to structural heart there, what we did is we looked at all the different structural heart things we do in the cath lab: TAVI, MitraClip, biopsies, ASD, PFO, left atrial appendage closure, adult congenital, pre-solid organ transplant, pulmonary hypertension. And we divided it into level 1, which is minor restriction in regular services. That is parts of Canada. I know that's also parts of the United States. Level 2, major restrictions in regular services. Again, this would be parts of Canada like Quebec and obviously New York, and we're thinking of them right now. We have many friends and colleagues. And then finally, level 3, where there's a complete inability to provide services. And for STEMI, this would mean thrombolysis versus just medical management. So as you go from level 1 minor to level 2 major, what we've said for TAVI is high-risk TAVI cases in level 1 with a short expected length of stay. And this is key. And I know we've got a wonderful panel here talking about minimizing the ICU footprint, doing patients awake or with minimal procedure or sedation, early mobilization with next day discharge. I think you're looking for a patient that's high risk, but that you can expect a good outcome from transfemoral TAVI and can be discharged with a very short length of stay. We used some of Harindra's data from Sunnybrook, low EF, severe AR with valve and valve, or recent hospitalization to characterize that. And I know Binny's going to be talking about some of the discussions you've been having at SCAI. For level 2, when there's now major restrictions, we would say limited inpatient cases that would facilitate hospital discharge. We did one of these cases yesterday, myself and John Webb, a great patient, 78, severe AS with severe AR, came in with refractory heart failure, when unable to be discharged. And we discussed with the surgeons that, you know, maybe this person would be someone would go to the OR, but not only would that require a ventilator and stay in the ICU, but also a much longer length of stay. So we made the decision that it made sense to do this patient. And we would do that now in a much more broader sense, i.e. younger patients at lower risk in order to facilitate discharge. I won't go through the rest of the document. It's published on Canadian Journal of Cardiology, and we're going to have a lengthy discussion. But I think that frames the discussion, Shami, and maybe we can move on now to...
That sounds perfect. Let's, Vinny, you know, I'm hearing an echo. Can somebody address that, please? Vinny, why don't you talk about an approach around the concept of essential or elective? You know, we keep hearing those terms, and sometimes they're being interchanged. Let's keep the slides back up, please. Or that's fine. We can hold off the slides. So, Vinny, what do you think? How do we differentiate what's essential versus non-essential? And I think that's a much better term to use here as opposed to elective. Can you go over your thoughts?
Totally agree, Shami. At our institution, we received notification from our administrators that we were to cease all elective procedures that could wait until after June 1st. So, of course, we were all sitting there saying, well, what in cardiology is truly elective? Because once we make a decision to refer a patient for a procedure, be it a coronary procedure or a structural procedure, most structural procedures, and particularly in the world of TAVR, it's generally once that decision is made, then you want to move along and get it taken care of. So there's definitely the term elective, I think for us doesn't really make a lot of sense. And I think your framework of essential is really a better way of looking at this. And there's certainly a gradation of what is essential, you know, and I think that's one of the things that we're all struggling with right now, because we all know patients that can wait for a period of time, and then we also know the ones that that really can't wait and must go right away. But there's a large gray area in between where defining truly what is essential, I think, is a challenge. And I think that's really a framework for our discussion today, and a lot of things that David has already hit on, as well as what we will be talking about a little bit later in the presentation.
So maybe one of the things that's pretty clear is an initial differentiator would be symptoms versus not having symptoms. And so if a patient is truly asymptomatic, that could be a non-essential, meaning we can defer those patients for some period of time. Would you agree with that concept, Kendra, that regardless of the valve area or gradient across the valve, if someone has no clinical symptoms, for now we can put them in the category of not essential for the next, say, 8 weeks?
I think that's reasonable, but we do have to remember that sometimes we have patients that have critical aortic stenosis where they've passed all of the metrics for critical, but they continue to not have symptoms. And so if you're going to delay those cases, then we have to have someone calling them on a weekly basis to make sure we don't miss treating them. Because those are the ones that I worry about the most when their valve area is less than 0.5 and their gradients are in the 60s. You know, those patients are critical aortic stenosis and we have to be careful.
Okay. Molly, what do you think from a symptom standpoint? What symptoms would make you say, I'm not comfortable waiting another 2 months before scheduling this patient for TAVR?
So I think if patients have New York Heart Association class 3 or class 4, I think that is a pretty good indicator of severe symptoms. And those two are at higher risk for having a problem in the future. And I think those can be done. So the New York Heart Association class 3 and 4.
So symptomatic class 3, class 4 heart failure. David, you touched upon ejection fraction and syncope or pre-syncope. Do you think those two should be added on to the class 3, 4 heart failure?
I think it's a moving target, Shami. Definitely in Vancouver, we're having our virtual heart team rounds, like I know many in North America. And although we're using horrendous data about low EF, recent hospitalization, severe AR for a valve-in-valve procedure, I think there's many different things we could look at, like gradient, crescendo symptoms, recent syncope, at least in our institution, has been a very high-risk feature. So it's dynamic, and I think you have to go with your clinical judgment, both you and the heart team.
And going back, Vinny, to you, what about patients who have been hospitalized, say, in the previous 1 to 2 months? And it's unclear what the reason for hospitalization is. How do we handle those patients with moderate to severe aortic stenosis? Not moderate, severe to critical aortic stenosis.
Yeah, I think that's important. We see a lot of patients who get admitted for symptoms that are thought to be aortic stenosis, and they may have severe aortic stenosis, but when you really take a good history, it probably wasn't because of the aortic stenosis. So a classic story is the elderly patient who was walking across the living room and tripped on the carpet and fell, and they come in with syncope, and then everyone feels like, oh boy, we got to replace this valve as soon as possible. I do think that it's going to be very important to understand whether or not the symptoms that got him in the hospital was truly due to aortic stenosis. And I fully agree with Molly. If they were admitted within the past 30 days, and you know that's sort of an arbitrary number, but I think it's a reasonable point to look at. And it is fairly convincing that the symptoms were secondary to aortic stenosis and not just some other innocent bystander, or perhaps not so innocent bystander. I think those are patients that are very reasonable to consider treating during this crisis. Now, we also have to weigh, and I think David's framework was really spectacular in terms of looking at where your institution is in dealing with the crisis and what the capacity is, because that also changes the algorithm a little bit about how you make decisions on these patients.
So, well, that's a natural segue into our next question. So how are you handling it in Boston? Can you maybe put it into context of what the overall prevalence of disease, both in the community as well as in the hospital?
Sure. So, you know, in Boston, we're certainly not at the level of New York or New Orleans or where Detroit seems to be going. We're all bracing ourselves for it. At our institution at Brigham and Women's, we are certainly seeing the patients come in, but we are not yet at a point where we thought we would be, and but we're also not necessarily comfortable that we're going to stay that way. To be fair, you know, I was in the cath lab today. I think we probably could have done a lot of these patients, but again, we're just respecting the request of the hospital administrators, which I think is a very reasonable one right now, given that we don't know where this is going to go. But I think right now we're fully expecting to start to see the surge here in the Boston area probably within the next week, and then I think things will get pretty sticky.
Kendra, what are you doing in Atlanta and at Emory presently, and what are you planning to do over the next, say, month?
So we're lucky. Emory was an early adopter of minimalist TAVR. Our program already relies on nurse-led conscious sedation. So we have an advantage there. But the same, like what Molly was saying, class 3, class 4 patients, patients that we cannot get out of the hospital, we're going to go ahead and treat those patients. But already 85% of our patients are done with no anesthesiologist. They go to the floor and they go home the next day. So we're in a different situation than many institutions who are just starting programs or still relying on general anesthesia. As a surgeon, I'm being asked not to do open surgeries because they're going to rely on ventilators and ICU beds. For these TAVR patients, if we can be selective and choose patients who can go down the minimalist pathway, then we can be able to treat them without utilizing those very scarce resources.
Okay. Molly, what are you doing in Dallas?
Well, we too aren't seeing many COVID patients yet. We keep being told that the surge is going to happen in the next week or two, but we have stopped all elective cases just like everyone else has around the country. As far as our TAVR cases, we have been doing virtual TAVR meetings, virtual TAVR clinic with both a surgeon and a cardiologist. We usually see all patients together with a couple of surgeons, couple of cardiologists. We are now rotating 1 and 1 and we're pretty much following the guidelines of critical AS, anybody with syncope, and anybody that has severe symptoms like 3 or 4 New York Heart Association class, or who's been recently hospitalized or hospitalized multiple times.
Okay.
So that's what we're doing.
This might be a good time for Kim to tell us how are you handling from a valve coordinator, and you oversee a number of coordinators. How are you handling it over there, and what is the approach you are taking present?
Well, it has been a shift in care to make sure that these patients are safely monitored and ideally kept from being admitted for any reason. So what we have done is that a lot of our team has switched over to working remotely, and we've been able to do that. And we've been able to do that by carefully detailing roles and responsibilities, so we are sure that there's no piece that is missed. And with that, we take very great care to closely monitor these patients at least weekly. Again, risk stratify them according to the criteria all have discussed as a heart team. We agree upon the risk stratification. All these patients get called weekly. Included in that call is COVID screening, screening for symptoms, symptom progression, and any changes. We also reinforce heart failure management, self-management. And then we do a safety check. Do they have an ability to get groceries? Do they have their medications? Can they manage their medications? And do they have support? And are they practicing safe distancing? All of this gets documented in a template and a weekly review again, because recognizing that risk stratification is fluid.
So I certainly, at our place, I can tell you what's happening in San Diego and at UC San Diego. California is one of the earlier adopters of the shelter in place, and all of the patients or any individual over 65 was sheltered at home a few weeks ago. And what we have seen is 2 weeks ago, we had a slight increase in patients with COVID-19 being admitted to UC San Diego. But over the last, say, week or so, there has been a plateau of patients that are intubated as well as patients in the hospital. Just like everybody else has pointed out, we are prepared for that surge. And the balancing act is, are we risking patients when we bring them in outside of their safe home, a lot of our elderly patients over 65, to potentially exposing them to COVID-19? And how are you all addressing that issue? So maybe I'll start with David, and then I'll ask everybody, is that a concern that you've heard from your patients?
So we're in a very delicate balancing act right now. I think all of us who aren't already in level 2, level 3, where infrastructure is now severely compromised, But in areas where we are still able to do some high risk essential outpatients, which patients should we do? Balancing that with that we've shut down most of our elective procedures to make capacity. In our 3 big hospitals here, we have 4,300 empty beds right now as we expect the peak in the next week. So I think it's all about risk versus benefit. Is that patient at high risk for a cardiovascular event in the near term? If they are, I would argue that the benefit outweighs the risk. And as was said by Kendra and Molly, if you can predictably have a patient come in the morning, be done using appropriate PPE, and go home the next morning with a minimal ICU footprint and without influencing other areas of the hospital, I think you're still doing a service to that patient and their family. So it's all about appropriate risk stratification, doing the right patients, and also being very cognizant that as cases and as the pandemic escalates in your region, you need to be dynamic and be able to stop cases, transition in very short order, not days and weeks, but literally within a day.
So what I'm hearing is the minimalist TAVR certainly keeps a relatively short length of stay, limits the amount of resources that are utilized. One of the new things we've started doing at our place is we are testing every patient for COVID-19 who's scheduled for any surgery, urgent or what I'll say essential, because we're also not doing any elective procedures. And we have started doing that. Are any of you doing that at your places?
Shammy,
No.
this is Benny. Yeah, we haven't. We have not started doing that yet.
So this is interesting. This just started this week, and starting next week, that is an option that will be available for us in the cath lab and EP lab. So we're trying to figure out how that will best be integrated into our clinical care platform. Because David, as you pointed out, we have been preparing for this surge for now 2 to 3 weeks here in San Diego. And yes, there's been a slight increase, but we certainly don't have the number of patients that were predicted to be in the hospital presently. That doesn't mean that it's not
it's a very unusual time, because I have colleagues that are looking, and from a cardiovascular footprint, we know these patients are all at home, and we know that the rates of MI and deterioration with severe AS are the same. So it's almost like a dam is building, and we're looking around and we're seeing our institutions, which for many of us across North America are empty as we're waiting for the surge to come. So trying to be very judicious about which patients to do and looking at that benefit versus risk ratio is very challenging. I know locally, we obviously screen for influenza-like illness symptoms. We were screening for recent travel, but at least in British Columbia, now our rate of community spread is high enough that that's probably not good enough. So maybe going to a testing policy for all of our essential outpatients is where we should be going as well. That's great advice, Shammy.
So one of the other questions, Molly, maybe you'll tackle it. I have you tackle it first. Is as we're trying to fit. So what I'm hearing is class 3-4 heart failure, pre-syncope or syncope, compromised ventricular function in the presence of severe to critical aortic stenosis. We should not be waiting on those patients. Those are essential procedures in essential patients, and waiting might actually be harmful. Even as short as waiting for 4 to 8 weeks. Now, Molly, who makes the decision at your place? Who has the ultimate say on this? Is it the administration? Is it the heart team lead? Is it as a group? Who's going to make that decision for the individual patient?
Yeah, so that's a good question. So at our institution, the administration has actually let us as the heart team make that determination. And I run the medical percutaneous program, and then my partner, Catherine Harrington, runs the surgical side of it. And basically, we still have a virtual meeting every Monday amongst the whole team, and we go over all these cases. So we have looked at our schedule because we were about 4 weeks out. So we looked at our schedule and we started calling patients. We moved patients that didn't fall under those guidelines. And then if there's any that we may not argue about but are concerned about, then Catherine and I will make that decision. So our administration has pretty much left it up to us, up to the heart team, and it has worked really well.
And are you doing any cases that require general anesthesia or alternative access?
Yeah, actually, we tomorrow have a transcable approach, and our anesthesiologists are, so we have a certain group of anesthesiologists that work with us with the TAVR. It's the same 4 people, and so they're part of the discussion. And we do most of our, I would say 90% of ours are conscious sedation, but if they do have to be intubated for whether it's alternative access, then they're very much aware, and they actually wear PPE. But I like your idea of being able to test. It's just we haven't had a test up until like a couple of days ago that we could get back rapidly. So that's a good idea.
Kendra, Emory helped lead the minimalist approach. So how are you doing, not the minimalist patients, but the other ones? I know the majority are done in a minimalist manner, but are you still treating patients who need to be intubated with alternative access?
We've been very aggressive with really clearing our schedule, first and foremost, to protect the patients. We didn't know if we were going to get an onslaught of COVID patients. And so as the co-directors sat down to look at this problem, we cleared the schedule. And then we went back and really started triaging patients who we felt couldn't wait. And yes, some of those patients have been under general anesthesia with the idea that they would not go to the ICU and that we would still be able to get them home the next day. And I think that's the critical piece. Yes, we were using the ventilator for the procedure, but they extubated in the lab, and then they went down our normal recovery. I think that it would be very hard right now to justify doing a novel procedure or something where you anticipated a patient being in the ICU for an extended period of time, especially intubated. So when you're looking at the patients, those that are going to follow more like a typical cardiac surgery patients, we should be pretty thoughtful about.
Okay. And the decision at your institution is made by the heart team, and the administration allows you to do that?
So the decision to actually do the minimalist ones, we have to clear it with the cath lab and our leadership, just so they know. Anything requiring a ventilator actually has to be cleared through a very complex series of checkoffs. I send a note to my boss, who sends a note to their boss, and make sure that we have a ventilator available, we have an anesthesia team available, and if we needed an ICU bed, that we can predict how long that patient would be there. So that's partially why we're trying to avoid those. But in terms of which cases are being done, that's decided by our heart team, exactly like what Molly described. We're still having a virtual heart team meeting every Monday to discuss these cases. We are calling these patients on a weekly basis to make sure their symptoms aren't getting worse. We're trying to really be thoughtful about who we bring into the hospital during this time. And one of the things that I personally think is important is that we are adding to our consent a discussion about COVID. You know, if you bring an 80-year-old from their home, although they're in class 3 heart failure, they have to know that we have COVID patients at the hospital. And so we added that to our consent.
Okay. Vinny, can you tell me a little bit about your heart team? Is it still the heart team making the decision? And how often are you meeting?
Yes, it is. We fortunately don't have too much input from the administrators. I mean, obviously, they want us to keep electives to a minimum, and we have done that. We understand the importance of keeping these patients out of the hospital and keeping the beds open. But if we have a patient that needs to go, it's the heart team that ultimately makes that decision and moves forward. We're a relatively small heart team in terms of physicians. We have 2 interventional cardiologists and 2 surgeons, and we all tend to think alike. So I think we make a fairly good consensus decisions. And I think, you know, everything that we're doing, well, in terms of how often we meet, we still meet once a week. That's what we've always done. And I think we've heard over and over again from the panelists that everyone has a a very compulsive follow-up system to ensure that patients who ordinarily would be scheduled or are now being deferred are getting called, to ensure there hasn't been a change of symptoms or anything that might lead us to think about treating that patient earlier. So still weekly, still review of what we have in-house and our clinic patients, but also an additional review of the patients that we've deferred.
Okay. Maybe, Kim, you can tell me, when you talk to the patients, I'm getting some questions from the audience. I'm going to start interspersing some of those questions. David, hopefully you can see those questions as well. We can both talk about them. But Kim, when you have, are patients saying that we don't want to come in because we at the risk of being exposed to COVID-19, if you offer that to them?
Yes, I'd have to say, surprisingly, a large number of patients have stated that they don't want the procedure during this time. And I think this is really what brings to light the expertise of shared decision making. As Kendra said, we do want to be honest and open about the patient's risk for exposure, and that should clearly be part of the decision making as well as part of the consent process. I think the challenge comes when the expectations differ, or someone that we perceive as meeting the criteria as an essential may have reservations because of the COVID virus and the risk for exposure. I think that's where the more challenging conversations come in.
Right. And Kim, what are you doing at your place for the 30-day follow-ups as well as the 1-year follow-ups? What are you doing for your patients?
Yeah, that's a very good point. As we know, as part of the TVT registry, it does require a 30-day and a 1-year follow-up. Now, the registry has recognized the current situation of the COVID crisis. So at the 30-day and the 1-year follow-up, this can be completed by a telephone or a telehealth visit and documented as such. Now, included in that would be the KCCQ, the New York Heart Class. You can capture any hospitalizations and the reason for them. And they just instruct us to please note in the documentation that this is due to COVID crisis. Now, the other pieces that you can't capture by phone, the laboratory testing, the EKG, the echocardiogram, those can be scheduled at a later, safer date. And again, documented as due to the COVID crisis.
Great. One of the comments that somebody made is that it seems like we're describing two different types of patients: the high-risk patient who needs to be treated, and yet the low-risk patients from a recovery standpoint for the intermediate low risk. And I think there's a little bit of maybe there's a bit of a confusion there. We are not necessarily describing high-risk patients. We're describing symptomatic patients. So we think that the patients who should be treated are the ones who are clearly symptomatic. They might be low risk from a traditional risk stratification standpoint, but if they have class 3 or 4 heart failure symptoms, then or they're pre-syncopal, they are at symptomatically more advanced patients. Kendra, what do you think about that?
I totally agree. I think that, even if you're talking about surgery patients, we need to be really thoughtful about how long people are going to be in the hospital. And I don't think this has to do with your STS risk score. It has to do with what treatment does the heart team think is the best for this patient, given the circumstances. And if they truly are symptomatic and in class 3 or 4 heart failure, low EF, whatever your criteria are going to be, then we need to be discussing them. And frankly, TAVR is a great option for even our quote unquote low risk patients. I think at any time, this is a time when we need to really rely on the heart team. We need to be using our colleagues and being able to help these patients.
Yep. Now, one of the questions being asked is general anesthesia make it lower risk for exposure to everybody else in the team? So is minimalist really the way to go? So Molly, why don't you start trying to answer that question?
So that's actually an interesting question, because one of our anesthesiologists actually brought that up and said he was going to intubate every patient that came in for TAVR because of that. But, the intubation itself puts people at risk. And so the anesthesiologist decided not to do that and just to keep them, on the minimalist side. So I don't think we have an answer to that question, but I think that there may be something to what you guys are doing out there, which is testing these patients before they have a procedure. And then I think it would make everyone feel a little bit easier. Again, I think this also depends on where you are, because for us, we still don't have a lot of COVID patients around here. So, but as it ramps up, I think that anything that we say is going to change to correspond to whatever's happening in your particular hospital.
Right. Any other thoughts on that? Kendra, I keep coming back to you because you guys do a lot of minimalism. By the way, at UCSD, we do the same. Over the last 2 years, I can count a handful of patients that we have done with general anesthesia, and almost always for alternative access. What would be your answer to people that say, well, general anesthesia might be protective?
I don't agree. I think that it's a risk to the anesthesiologist that aerosolized virus that could be contaminating the operating room. Just for our patients to undergo intubation in the operating room, every person in the room has to have an N95. We're not allowed as the surgeon team or the heart team to be in the room because we're non-essential for intubation. They wait 15 minutes and then we can come in with our regular masks on. They are having us all wear shielded masks and additional eye protection. But I just don't see that general anesthesia is the answer. And certainly there's something to be said that the patients who are under general anesthesia don't do as well. I think that our pathway is a very safe one. We put a mask on the patient. And of course, we're doing all of the guideline-directed DICE or appropriate masking for the team. I don't think that general anesthesia helps.
All right, well, let's talk a little bit about PPE. And I'm going to start, David, with you. When you are doing the procedures for the team, and as I mentioned, we've decided here at UCSD that we will just be testing our patients for COVID-19. But even until that's routinely available, the rapid test, we understand, is going to be available, at least at our institution, by next Friday. I don't know how easy it will be around the country. But if we can rapidly exclude the diagnosis, that gives a lot of comfort and relief of anxiety for the team. But until that's available, what kind of PPE are you recommending, or you yourself and your team in Vancouver? What PPE do you use?
So I think it's a great point, and I'd like to just reinforce what Molly and Kendra said. I don't see a transition to GA as being the answer during the pandemic. I think build the infrastructure, a minimalist approach, no GA and early discharge is going to serve our patients well. The second thing would be, Shami, my goodness, there's like 30 amazing questions that have come in or more. So I think that speaks to the fact that we're probably going to need another webinar to answer some of these questions, because they're very pragmatic questions. And I know that we're going to be short on time. And finally, with PPE, up until this point, so literally today, everyone in our hospitals is wearing masks. I know there's comments coming in about, are we using up PPE that could be used on the front lines in the emergency? That's the decision made in Canada at a lot of institutions. We are doing our TAVI patients as normal. So with our surgical masks and our gowns, if there's any risk at all or any signal of influenza-like illness, we are using droplet precaution. For our high-risk cases, we did turn one of our labs at each of the tertiary care hospitals into negative pressure, and we would use full aerosol level PPE if there was a very high suspicion. But since we're talking about structural heart patients and there's a bunch of questions coming in, no, we are not doing COVID positive TAVI patients at this point. We're not considering doing balloon valvuloplasty on COVID positive patients at this point, but I'd be curious what the rest of the panel thinks about that.
So let's go to Vinny. Vinny, what PPE are you using?
Our protocol is that if they are COVID positive or COVID suspected, they will get full PPE with a face mask and an N95. We have not had that issue come up yet for a TAVR patient. If they are screened negative or known to be negative, then we will just use standard PPE. And for patients who, the only other group of patients in our hospital that we will use full PPE for, independent of COVID symptoms, are the STEMI patients. But again, most of this is dictated by the need to conserve PPE. Certainly, if we had a system like yours where we can test every patient coming in for a procedure, I think that would change that quite a bit.
So some interesting questions have come in. One is, has anybody in the group done or would consider an intubated patient with COVID for TAVR? And I guess the possibility is always there that such a patient could be in one of our institutions who is severely ill, or maybe mildly ill, but severely enough that they're intubated. How do we answer that? Quick around the group. Molly, would you do such a patient?
Unfortunately, probably not. I don't know. It hasn't come up, and but there's a 50% more, or I don't know. I guess if it depends on what you believe is the intubation mortality. A 50% mortality with COVID patients who are intubated.
So I'll give you a case. 0.7 valve area, intubated because of COVID in the unit. Now also has heart failure. Are you going to offer them TAVR?
Maybe BAV.
BAV.
I don't know.
Kendra?
Same. I think we would have to think about a BAV as a bridge. And if they survived the COVID, then we would come back and put a valve in later.
Okay. Vinny, do you agree with that?
Yeah, I think so. I mean, I've been asked whether we would do a BAV just to get a patient out of the hospital and then bring him back after COVID for TAVR. That I wouldn't do. I think if the decisions between BAV and TAVR just to get the patient home, I would just go ahead and do the TAVR. It's going to be a lower risk, better outcome. So the patient you described, who I think has a very high mortality from their COVID, I think I probably would potentially consider using a BAV in that case to see if we can improve hemodynamics enough for them to improve.
David?
So, yeah, I'm just not sure about the efficacy of the BAV, and it's not like we're talking about a 2-week period here. You're talking about likely months that we're going to be going through this. And I think it truly depends on where your institution is in North America. Are you level 1, where you can have that discussion? There's still capacity that you might consider doing a severe AS patient that's COVID positive, or are you level 2, where there's major restrictions? In which case, I think truly we need to treat people that we think are going to derive the most benefit. So using up that very limited resource as our cath lab footprint shrinks more and more and more, I think you really need to think long and hard about who is going to get that resource right now.
So I think there's a uniformity, and I would say at our place, BAV is all we would offer such a patient. If we thought that was contributing to a concomitant heart failure on top of the COVID, and that would be a heart team / critical care team multidisciplinary decision. And I think for anybody listening in, these are patients that we really have to think about as a long shot. And if their mortality is high from COVID, then doing something else where you potentially expose the team to high viral load and risk, that's something else that needs to be taken into consideration. What if a patient that you've done a TAVR on then subsequently develops COVID and doesn't survive, and you didn't suspect it up front? That's the question somebody's pitched, is will that count as a mortality for the TAVR program?
So that
Yes.
exact scenario happened to one of our colleagues in Europe, where they did a patient, unfortunately, they had a complication and required a short ICU stay. This is 2.5 weeks ago. The patient did go home, but then succumbed to COVID. It's very unfortunate. We're all trying to avoid that, but that is unfortunately a reality.
Okay, great. Questions are coming fast and furious. Somebody put a quick speak about MitraClip quickly. Okay, we'll speak about it quickly. The purpose of the webinar today was really not broadly structural heart, but I think it's important because it's almost always the same team taking care of the patients who need percutaneous mitral valve repair. And I think that short of somebody being in the hospital, and that is the reason why they're in the hospital, at our institution, we would not treat those. And so, Molly, what do you think?
That's pretty much what we're doing too. If the patient's in the hospital with severe MR and needs a procedure or MitraClip, then those are the ones that we're doing. If they're outpatient, then we're pretty much, trying to put them off. But if they're severely symptomatic and like degenerative MR and severely symptomatic, then we would probably do it. But otherwise, no.
And this will change as we get further along,
Right.
because who you might treat now might be different than 3 weeks from now. And then as the pandemic, this is crucial. And I know we're still early on, but as things start to decrease and restrictions ease, now you're going to have a very long wait list for all your structural heart procedures.
Yes.
And you're going to very thoughtfully determine how to increase your run rate. And I know a lot of institutions are not used to having very long wait lists for structural heart procedures. This is a reality in Canada we've dealt with because of our socialized medicine for many years. And it's a real challenge to figure out when you start ramping up who to do and when.
Okay. Kendra, are you doing any percutaneous mitral valve repairs?
So we have, and just as Molly described, these are going to be patients who have come to the hospital who are not going to leave the hospital unless you treat them. So these are high-risk surgical patients. They would have already gone down the MitraClip pathway, and they have to be treated in order to be discharged. And I think that's going to be where we kind of confine things. We haven't been in a position where people that we postponed are now more symptomatic. But certainly we're going to get there, and it's going to be a heart team discussion on individual patients.
Okay.
Shami, we've got a question that's come up 3 times in the last week in Vancouver, and I'm curious for all of our panelists. Aortic stenosis with concomitant coronary disease. It's come up on the thread multiple times. And I know for us in Vancouver, John and myself and our colleagues, Anson, Jan, Richard Cook, all of them, our threshold for multi-vessel percutaneous revascularization has changed. When they come in with multi-vessel disease, that's changed. But now our threshold for TAVI plus or minus PCI has changed. And obviously we're hopefully going to start next year a big study looking at this. But for now, it's a different world today than it was 2 months ago. And I'm curious for the rest of the panelists, what's happening in your institution?
So David, let me ask you for a second first. In Canada, are you routinely still doing coronary angiography prior to the COVID-19 in everybody, or are you using CTA in some patients?
So it's a combination, and it depends on which institution across Canada. There's been a very interesting chat going on the side of the screen here about should we be minimizing that and just do the angiogram at the time of the TAVI, which is an interesting question. But this is for people that specifically see of concomitant coronary disease, you think it's significant, it's proximal epicardial. Is that someone who now would go for TAVI and multi-vessel PCI during the pandemic who might not have prior to the pandemic?
Yeah, great question. I would say at our place, let me start you my point of view, and then we'll go around the group. We are currently still doing coronary angiography for patients who we think need urgent TAVR. And the idea is, unless it's a high-grade prox LAD and an unprotected left main, that we are not planning on operating. And so we have not done a CABG valve for the past few weeks. So in those patients, we would probably revascularize followed by TAVR. Otherwise, most moderate to severe coronary disease even, we're holding back, doing the TAVR and getting them out of the hospital.
Agreed.
Molly, what are you doing?
Yeah, we're still doing angiograms too before, or also we've been getting CT scans, and if there's no proximal, coronary disease, if we can see that on the 4D CT, then we won't do an angiogram. And, it's sort of in flux as well as, again, as more patients come into the hospital with COVID, we probably will end up changing those. But right now, again, we do not have surge yet. So we still are doing the testing beforehand.
But even pre-surge, Molly, we only have one cath lab open at our big major hospitals. We only have one OR running, usually just doing one patient. We're doing a quarter of the volume in preparation for the surge. Even in this phase, it's a very different reality on what we're treating percutaneously versus what would go for surgery.
Oh, absolutely. yeah, we're not treating much of anything. It's kind of funny how all of a sudden, you know, those stenosis aren't bad enough to be treated yet, you know? So it's the same, but we're also pre-screening so many patients before TAVR that we don't, you know, we've cut our volume, you know, dramatically. So as we're calling patients before clinic visits and asking, you know, their symptoms beforehand. And if they don't have many symptoms and they're doing okay, we're not even seeing them yet. So we're pushing people, you know, back.
Kim, can you maybe tell us how you're handling from a valve clinic standpoint, new patients, new referrals? What's the workup that is going on currently?
Great question.
Yes, this actually, in a way, is an even more challenging population because we don't have all the data yet. You know, we have our patients waiting on the list who we know what they need done and we know all about them. So this has its own set of challenges. So with the incoming patient, the new referral, the consults, we do have the virtual clinic, so where they're evaluated by a cardiac surgeon, interventional cardiologist. Now, based on their evaluation, we also risk stratify these patients as to the urgency of their evaluation. So for example, we were talking about cardiac cath. Do they need a cardiac cath based on symptomatology and history within 72 hours, within 1 week, within 1 month, or are we opting to defer that cath and have them evaluated at the time of procedure or based on their CT if there's any proximal coronary disease? We also look at their need for a CT scan. Are they symptomatic and their gradients are such that they warrant an urgent CT scan? Is that at 2 weeks, 4 weeks, or can they wait? And then they too get risk stratified as to how often do they need symptom monitoring. Usually with our AS patients, it's also weekly. And so those patients, we want to look for a progression of symptoms, any other issues. I do want to mention specific to the TVT registry, the TVT registry does not require pulmonary function testing or carotid screening. And we do that oftentimes as part of our practice, but specific to the registry, that's not required. So that helps a little bit there.
So Shami, I'm looking at my phone and I have about 100 texts during the last 45 minutes. I'm sure you're like that. One of them here is, again, you've already emphasized this, but it's important. We only have a minute or two left. The difference between a symptomatic patient who might be low risk and very straightforward for TAVR, who might be an ideal patient to do in this period of time before the peak comes, versus just talking about risk in general and STS risk. So I think it's important that you clarified that. And these symptomatic but ideal for TAVI lower risk patients might be the best patients to do. So again, just crystallizing that. And secondly, with the number of questions here about pacemakers and risk stratification and all of that, I think we're going to need another webinar, my friend.
I would agree with that. So as we're running out of time, let's make one comment about if we want to quickly finish, we do a patient next day. Should we do outpatient rhythm monitoring versus keeping them an extra day if they have conduction system abnormalities? And I think it really is institution dependent and individual clinical place. It depends on what the situation is, what kind of conduction system abnormality. We certainly do not want to send anybody out of the hospital who has a high risk for an arrhythmic or complete heart block event in the ensuing 24 hours. So there will be some patients who will have to be monitored for longer, but certainly the idea of outpatient 30-day monitoring sounds great. In the last couple of minutes, I would like, Molly, for you to put up the slides from Binny. And Binny's got some slides that crystallize our takeaway points from today's webinar. So we've got a couple of minutes here. Binny, why don't you go forward with the slides?
Sure, thanks, Shami. And this is really born out of a discussion between the ACC Interventional Council, the ACC Cardiac Surgery team, as well as SCAI. And over the last week, much like David did in Canada, we sort of talked about what do we think is important in making treatment considerations or treatment decisions during this era. And we thought that it was important to think about patients in three buckets. So one are the patients who have symptomatic severe aortic stenosis, patients who are minimally symptomatic but have truly severe and critical AS, as well as the asymptomatic group. So next slide, please, Molly. So in terms of symptomatic severe aortic stenosis, the first group and probably the easiest one to deal with are the inpatients with severe AS. And in particular, in patients who have a reduced ejection fraction, as we discussed, New York Heart Association class 3 to 4, which seems to be pretty uniform amongst all of us, as well as syncope, which is a high-risk finding. We feel that these patients really should be treated, provided the capacity is there to do so, not only to help improve their prognosis, but to also get them out of the hospital. But it's important, again, to keep in mind that their symptoms that you're treating are truly from their AS and not from something else. Because if they can be deferred, it's probably not unreasonable to do so. But we also all have outpatients with severe to critical AS, and I think we all felt that it was reasonable to consider treatment in outpatients who have class 3 to 4 heart failure. There are patients who are progressing or starting to get worse right in front of you, or patients who may have syncope. Next slide. This is the real tough group, the patients who are minimally symptomatic but really have very severe to critical aortic stenosis. And there's a lively debate amongst our group in terms of, well, where do we draw that line of somebody who really ought to be treated, even if they're just minimally symptomatic? And I think the real issue here is that there isn't really a good cutoff point. There's no clear-cut data to say that a Vmax of 5 or a mean gradient of 50 or 60 or what have you. And I think it was going to be very controversial to come up with exact criteria. So this is where I think clinical judgment really has to play a role here. But certainly looking at things like the Vmax, the mean gradient, the valve area, dimensionals index, where is your institution and ability to treat that patient, and clinical judgment will then just help you dictate when you decide to treat that patient. But if for patients who are going to be deferred, I think you've heard consistently from the group here that these patients should be followed up with a weekly to bi-weekly check-in depending on their symptoms. We've actually taken to going ahead and scheduling a TAVR date for sometime in the late spring or the summer, hopeful thinking that we can get them taken care of then, but at least having them in the book so that if we need to move them, we can always move them back a little bit. But again, being ready to provide an urgent TAVR for patients with clinical deterioration. Next slide, please. And then I think the asymptomatic patients, I mean, I think there is data, observational data, and now we have some randomized data, at least surgical from the recovery trial, suggesting there may be a benefit to an earlier intervention. But I think in this particular situation, almost independent of the severity of their AS, we felt that perhaps it's best just to watch and avoid those patients coming to the hospital, potentially contracting COVID while they're here. But again, a weekly check-in, urgent TAVR for clinical deterioration. And the final slide, please. And the final slide is coming up, really just has to do with the clinic. And I think you've heard from all of this a very consistent message. One thing that was very important for us was to maintain our clinic schedule, so to keep them as busy as they've always been, because there are going to be patients out there who are going to need to be evaluated and at least put in the books as someone to watch. We have gone to pretty much exclusive use of telehealth options. We didn't talk about that too much today, but I think there's a lot of great options out there to really get a full TAVR evaluation electronically without making the patients come to the hospital. Again, we go ahead and book patients who need to get done, give them a date later on in the late spring, early summer, with the ability to move it if we need to. Weekly check-ins, as we discussed, weekly meetings, I think, as everyone's doing. But as part of your workflow, think about the patients that you deferred and what the most recent check-in suggested and whether or not you think about treating them earlier. And then finally, there are going to be these challenging, controversial cases, and it's going to be very important to have a single, interventional cardiologist and cardiac surgeon sort of working together as the arbitrators of these challenging cases, where everyone understands that what these two decide will be what we do for that patient at this critical time.
Great. Thank you, Vinny. Let me just finish up. There's some added comments. I'll address them quickly. First, what about unstable angina? I think unstable angina independently of TAVR is an essential procedure, and we are going to have a separate webinar addressing ACS and MIs. So that'll clarify that. Second is somebody also put in, well, how are these any different from any other guidelines prior to COVID-19? And I think the important thing is we're not saying the guidelines are any different. They are exactly the same. It's a matter of the degree of urgency. Which patients should not be delayed for 4 to 8 weeks versus, so it's better to think about it as essential in the short term, not whether the procedure is indicated or not. So now let me finish up. I want to thank the panelists and David Wood. This is the first time I think we've done a webinar together between SCAI and the Canadian Association of Interventional Cardiology. So I'm very, very excited about that partnership. The fact that we can work together because we're all facing very similar issues and consequences of our decisions affect all of our patients, and we want the best outcomes for our patients. I appreciate the time that all of you spent as panelists, and David, you as well. And we'll plan on doing more of these, both that are originating in Canada as well as in the United States from SCAI. David, any final words from you?
Just wanted to say, agree. This is the start, hopefully, of many more endeavors together to help clinicians and patients. And I just wanted to say, please be safe, everyone. Do what you can to obviously protect your patients, but also yourselves and your heart teams. Be well.
Great. Thank you very much.
Thank you.
Thanks, everyone.
Thank you.
Thank you.